Welcome back to another episode of What Did the Patient Say with Doctors Dana and Lauren Brindisi, sisters and owners of Carolina Functional Neurology Center. We are bringing you inside information from real conversations we have with patients on a daily basis. We get asked the same questions and want to spread the truth on health and healing because we believe everyone deserves to know the answers.
Hi guys, welcome back to another episode of What Did the Patient Say? Today you get me, Dr. Dana Brindisi, owner and founder of Carolina Functional Neurology Center. Today we're going to talk about a topic that we discuss often with our patients in the clinic. We're talking about the hypothalamic-pituitary-thyroid axis. Now, we get a lot of questions about this from not only our patients, but people online, because the thyroid is a very tricky thing to control. And there are so many moving parts to it that a lot of people don't even know. So that's what we're going to discuss today so that you guys have a better understanding of when you go see your doctor, kind of what they're talking about, and also, if some of your markers are considered to be normal, but you still don't feel great, what that really means for you, and what are maybe some other things that you want to look into or ask your doctor to look into. Or see a different specialist that maybe can dive a little bit deeper. So what people think about when we talk about thyroid is the actual thyroid gland. Now, that is a piece of the puzzle, but that's not the only piece. So when we talk about the brain-thyroid connection, that's because the cascade at which your thyroid is able to make thyroid hormone starts in your brain. It starts with your hypothalamus. And your hypothalamus is really a relay center in the brain for a lot of different information, but your hypothalamus also connects a lot of other metabolic processes in the body to the brain. The thyroid and your endocrine system at large is one of them. So endocrine system is your hormone system. So what happens is that your thyroid is sending signal to your pituitary gland, also in your brain, that then sends signal to your thyroid gland, but also your other glandular organs that produce hormone. So testes, ovaries, adrenals, which is probably what a lot of people have heard of when they talk about HPA axis, which we're going to do another episode on that because a lot of people have questions about that, and a lot of people get diagnosed with adrenal dysfunction or, adrenal fatigue, and they're not really exactly sure what that means because it isn't just a blanket statement to say, okay, I'm tired, therefore I must have adrenal fatigue. It's not that easy. Same thing with the thyroid. So again, the hypothalamus is sending signal to your pituitary gland. Your pituitary gland is then sending signal to your thyroid gland that's telling it to make thyroid hormone. Now that signal from the pituitary gland to the thyroid gland is your TSH, so thyroid stimulating hormone, which anybody that has gotten their thyroid checked or knows anything about thyroid, you're familiar with that term often because that is a lab marker that we can measure. And it's one of the few markers that get run almost always when we talk about thyroid. But again, what most people don't know is that is coming from the brain. It's coming from your pituitary gland. And your pituitary gland is saying, hey, stimulate the thyroid gland to tell it to make thyroid hormone. So that's where you get your TSH. Once the TSH reaches the thyroid gland, it's got that signal. It says, okay, I'm going to make thyroid hormone, which is T4 and also T3. So some people get both of those levels checked when they run labs. And what that's telling us is you have an active form of thyroid hormone and you have an inactive form of thyroid hormone. So you have both. When it gets produced by the thyroid gland, there's a couple things that happen. The thyroid gland then has feedback loops to the brain to say, okay, thank you, we did our job, I did my job. You have two sides of your thyroid gland. We did the job, we made the hormone. That amount of stimulation was perfect, or we couldn't make enough hormone, we need more, or we made too much hormone, we need less. That's where you see the fluctuation of that TSH level, and that's why when that TSH level goes high, people get diagnosed with hypothyroidism, right? When the thyroid gland is sending that feedback signal to the brain saying, we didn't make enough thyroid hormone, we need more stimulation, it's pumping out more TSH from the pituitary gland to tell it to make more thyroid hormone. Hope that makes sense to everybody, because people get confused that when that TSH level's high, it actually means you're hypothyroid. So that's how that gets set up from a physiological perspective. Now, once your gland makes the hormone, that T4 has to be converted into T3. T3 is the active form of thyroid hormone. And what that means is T3 is what's used at a cellular level. So you have cells, you have receptor sites on the cells, and then you have the hormone that binds to that receptor site. T3 is what binds to the receptor site at a cellular level. So after the gland makes the hormone goes to your gut, it goes to your liver, and it gets converted. And it gets converted to multiple forms of T3. So we get markers that we can run on lab work. So you can run a T3 level. You can run something called a free T3 level. And then you can run something called a reverse T3. Now, there's also a conversion to a form of T3 called T3 prime that we do not test on lab work. So we're going to set that aside. When it gets sent to the gut and to the liver, it gets converted. We need most of that T4 to get converted to T3 so that we can use it at a cellular level. Now, functionally, when we run thyroid lab markers, we run a lot of those different markers. So we run T4, free T4, T3, free T3, and reverse T3. The important thing about running the reverse T3 is that it will tell us if you are over or under converting T4 to either the appropriate active form of T3 or if it's getting converted to reverse T3, which is not usable at a cellular level. So most of the time people don't get this marker run, but you may see fluctuations in that T3 level if somebody is running that level, which is super important and should be run on every routine thyroid panel that you get done to get an idea. Because again, that T4 you can't use at a cellular level. So all it's saying is, okay, we know that the pituitary gland sent the signal. We know that the thyroid gland made the hormone. And if those two markers are normal, but you still have symptoms of thyroid dysfunction, most likely what's happening is your body's not converting that T4 to T3. So while you have adequate amounts of T4, you don't have a way to use it in your body. So once it gets converted, and again, once you understand, is it getting converted correctly or not, then that hormone has to be transported to the rest of your body. And the way that we transport that hormone is through our blood. But the way that it gets transported is on what's called a carrier protein. So the way that I really describe this to my patients oftentimes is to say the carrier protein is like the school bus. The hormones are the kids going to school. You have to have adequate amount of buses to transport the kids to school, and the kids got to get on the bus. So once it gets dumped into the bloodstream and it gets attached to the carrier protein, that's where you see lab markers talking about T4 and free T4, or T3 and free T3. T4 and T3 is referring to bound hormone, which means that it's bound to the protein. And when it's bound to the protein, it's not usable at a cellular level. It's bound to the protein because this is how we transport it through the body. Once it gets to a cellular level, there has to be a physiological process that happens so that the kids can get off the bus. And so that that free hormone gets unbound from the transport protein. And now it's free floating hormone in the bloodstream, and your cells are able to pick it up and attach it to a receptor site. Without it being that free hormone, again, it's too big. It cannot attach to the receptor site at a cellular level with that protein bound. So again, if we're running lab markers for thyroid and we only see T4 or we only see T3, the piece of the puzzle that you're missing is Did the kids get off the school bus? Do we have free hormone to utilize at a cellular level? And if the answer is no at any stages of this thyroid cascade, then your lab markers might look great from what they're looking at, but you actually don't have the ability to use the hormone. And if you don't have the ability to use the hormone, then you don't have the process that comes along at a cellular level with transcription and all of that to produce what the body needs to use that hormone adequately and appropriately. So this is where a lot of people get stuck with thyroid issues, is that their general labs, when we look at TSH from the pituitary gland and we look at T4 from the thyroid gland, look really good. I hope after taking a few minutes to listen to this podcast that those of you that are realizing like, man, I don't understand, everything looks normal, my doctor's telling me my labs are normal, I don't feel normal, I'm tired, I'm gaining weight, I'm losing my hair, I don't have any stamina, I don't have any energy to do this, my appetite's changing, my gut dysfunction is getting off. There's a lot of things that we notice, and I'm really referring to hypothyroidism. It's the most common form of thyroid dysfunction that we deal with in the United States. 90% of those cases are autoimmune thyroid disorder, meaning most of those patients have Hashimoto's. We'll dig into that just a little bit here. But I really want to make sure that everybody kind of understands that cascade, because it starts in the brain. It starts in the brain and it ends at a cellular level. And if you don't have all of those markers run, it's nearly impossible to say, yes, it's working correctly, or no, it's not. The only thing you can say is the pituitary gland sending the signal, and is the thyroid gland making the hormone? So that's kind of where we dig a little bit deeper from a functional perspective, and we test about 10 thyroid markers, including antibody levels, on all of our new patients, because again, it starts in the brain. So when we're doing neurological rehab, we want to make sure that the thyroid gland is functioning appropriately, because again, we got feedback loops to the brain. So if that hypothalamus is not doing its job correctly, we need to know that, and then your thyroid hormone gets used on almost every cell of your body. You need that for the cells to work appropriately. So that's why we as functional neurologists look in depth at thyroid, but also it's important for everybody to make sure that that gets checked, and make sure that you get all of these markers run when you're getting routine thyroid workups, so that you get a clear picture, so that you're not told everything's fine and normal because these two markers are adequate, and that you know exactly what's happening after that thyroid gland has made the hormone, and what's happening with the hormone after that. So there is a lot to the story after that. And then, as I mentioned, the majority of cases of hypothyroidism are autoimmune in the United States. And what that means is that your immune system is producing antibodies to your thyroid gland and to the thyroid tissue. So the way that I describe this is, if we were to encounter a virus or bacteria, right, our body, our immune system has mechanisms in it to get rid of those things, because we recognize those things as foreign to the system and something that's an insult to the system and something that we want to get rid of. So what does the body do? What does the immune system do? This is the virus. The immune system will tag the virus with a flag that we call antibodies. And that flag is telling the rest of the immune system, like, hey, this is a foreign object that we don't want in our system. This is an insult to the host. We need to get rid of it. So here's your tag. When you come around and you're activating those soldiers to clean everything up, this is how it knows how to do it. It has a recognition marker on it. Now, when we have autoimmune disorder, the same thing is happening. However, that flag, that tag, is being tagged on tissue that we have in our own body that technically shouldn't be recognized as foreign to our immune system, but the immune system has gone a little bit awry, and now we're getting those tags to tissue that we have. Now, most people are not getting their thyroid gland removed because they have autoimmune thyroid disorder, but it needs to be managed because you're not going to get that tissue removed, which means that your immune system is constantly being activated to say, man, we got a foreign invader. Tag it, we got to get rid of it. Tag it, we got to get rid of it. Tag it, we got to get rid of it. And what happens is your immune system comes in and it starts to destroy your thyroid tissue. Now, this is the same process that happens with all autoimmune disorders, just depending on what tissue that immune system is tagging. Now, when you have autoimmune thyroid disease, most of the time, the traditional treatment is to treat the glandular dysfunction. Do you need more T4? Do you need more T3? Do you need exogenous hormone to help you because your immune system has destroyed enough of your thyroid gland that it's not able to produce enough hormone? We find that we pick up people who have autoimmune dysfunction of the thyroid without thyroid disease, meaning they do not have hypo or hyperthyroidism yet. What we can kind of theorize and hypothesize is that because we know if you're producing those antibodies that it is destroying the thyroid tissue, at some point in your life, and this can go faster or slower depending on the human, the host, you're probably going to develop thyroid disease at some point, because once you destroy enough tissue, the gland can't do its job. It can't make the thyroid hormone. But even if you already have thyroid disease and you know that you have autoimmune thyroid disease, you want to address both components of that, meaning if you need some help with the hormone replacement itself, and people can do this via supplementation, people can do this via medication. It's whatever route is most appropriate for you. But the other piece of it is addressing that immune dysfunction, which really falls flat a lot of times. And from a functional perspective, this is something that we consider to be extremely important because, as a lot of you know, with autoimmune disease, things can be relatively well managed if managed correctly. And that's where treating the immune piece of it is really important. So making sure that you're working on reducing inflammation. Depending on what type of autoimmune disorder you have, there may be different types of treatments. There may be differences that you want to incorporate into your nutrition. There may be supplementation that you want to onboard that's going to help keep the inflammation down, help reduce the signal that the immune system is sending to destroy the tissue that's in your body. And addressing both aspects of that, or at least addressing the immune piece if you have not developed thyroid disease yet, is really, really important, because if you haven't developed thyroid disease yet, it means that you haven't destroyed enough tissue, which is great. And you want to keep that narrative going for as long as you can so that you don't end up with a full-blown thyroid disease. So that's kind of the gist. We've had a lot of questions about people asking more nitty-gritty about some of this stuff. So if this is something you can relate to, I hope that this has been really helpful and you find it interesting. Obviously, every case is different and there can be dysfunction at multiple levels of that thyroid cascade. And it's really important for you to understand where that's coming from. And that really makes a big difference when we talk about treatment. And also just to let everybody know, your thyroid and your hormone system, right, is constantly fluctuating and moving, right? And this is why a lot of times people get their medications changed, they get their supplement regimen changed. Once you go on for treatment, again, whether it's medication or supplementation, however you're choosing to work with it, it's something that you constantly have to monitor. It's not something that I can just be like, all right, take this dose from now until the rest of your life, right? Your hormonal system is impacted by a lot of different things. So a lot of people do find it frustrating that things have to fluctuate and change. But please understand that that is the nature of what you're dealing with from a hormonal perspective. Now, should it have to be changed every 3 months for the rest of your life? No, that's not realistic. If that's what's happening to you, then you're probably missing a piece of that puzzle. Usually it can take anywhere from 3, 6, 9, 12 months to get things stable once you start treatment. But from there, every 6 months to a year, you want to make sure that you're getting those levels checked. If you're having any fluctuations in your symptoms and you feel like things are not staying stable for you, you want to make sure that you get them checked. But the reality of it is that it's an ongoing maintenance. But once you find a dose that really works for you initially, you should be able to maintain that pretty well, as long as you're getting, like I said, every 6 months to a year, getting checked, making sure that that's still appropriate for you. And that's something that you will do for the rest of your life at this point. And just know that kind of going into it, because I know that a lot of people that we work with, we acknowledge that up front. And maybe sometimes when you're utilizing medication, they may not. So we find that people get very frustrated with having to change the dosage of their medication regularly. Now, again, if it's new, you probably have to change it more frequently until you find that therapeutic dose for you as an individual, versus like you've done the work up front, you've kind of changed these doses, you found a level that really fits with your body, you feel good. You should be able to maintain that relatively over the course of 6 months to a year without having to constantly fluctuate and change. So just know that going into it. And if you guys have any other questions for us regarding the thyroid, the hypothalamic-pituitary-thyroid axis, what we do from a neurological perspective to help with some of these things, we are open. And again, we are making these videos in reference to the questions that you guys ask us. And like I said, we do have a video. If it hasn't already been posted, it will be about the hypothalamic-pituitary-adrenal axis. I know a lot of people have questions about that. So I hope you guys have found this interesting. I hope that you have found it informative and helpful. And as always, let us know if there's anything else, other questions that we can answer for you. And like and subscribe to our channel. You guys are feeding this information. You can follow us on Instagram, on Facebook, we're on YouTube, and these are also in audio form on Apple Podcasts. So again, I hope you enjoy. Everybody have a great day, and we will talk to you soon.